Okay, so the adrenal glands are at the top of the kidneys, a little triangular little gland sitting on top, like a little hat. Produces hormones, several hormones, okay? And sometimes it's stimulated from the pituitary, as we just talked about, right? When we're talking about cortisol. But hormones that regulate metabolism, immune system, blood pressure. Remember that? We talked about kidneys and the adrenals and regulation of blood pressure. And response to stress hormones, okay? So there's two parts to the adrenal gland. Where there's an issue or tumor or a problem affects the hormone that's produced from that portion of the adrenal gland. So you have the medulla in the middle, right? And the cortex on the outside. There's lots of blood vessels in the medulla, and that's really important when we're talking about post-op care, right? If we're removing tumors and things, very, very vascular. So lots of blood vessels there, that's important to point out. So in the medulla, you're primarily talking about your epinephrine and your norepinephrine is stemming from there. And then the cortex is what we're focused on right now. So adrenal cortex hormones, those are your corticosteroids, right? You've got glucocorticoids and you've got mineral corticoids. I can say it. Mineral corticoids. And then the androgens, so all from the outside portion, right? So your progestins and your estrogens, growth and development and sexual activity. Primarily, we're talking about glucocorticoids and mineral corticoids. Glucocorticoid has glucose in the term there, so we're dealing with sugar, right? Metabolism and your stress response, and the primary hormone we're talking about here is cortisol. You all have heard about cortisol, right? And then we're talking about mineral corticoids produced in the cortex, dealing with salt. So, anytime we talk about salt, we're talking about fluid and electrolyte balance. Sodium retention and potassium excretion, once again. So you know we're going to be talking about blood pressure. And this is why the adrenals help regulate blood pressure. This is what you guys, I think, learned a little bit way back, maybe in MP1. So now we're getting into it. Primary hormone we're talking about when it comes to mineral corticoids is aldosterone. So cortisol and aldosterone. Got that written down? So there is a negative feedback loop, right? So the hypothalamus is going to secrete the corticotropin releasing hormone, which tells the pituitary, the anterior part, remember we just talked about anterior, going to tell the anterior part to secrete the adrenocorticotropic hormone, that ACTH is coming from pituitary. Right? I briefly mentioned that in the very beginning of class today with the adrenals. Pituitary is responsible for sending ACTH to the adrenal cortex. Okay? And in the adrenal cortex is where cortisol is produced. So as cortisol increases, it sends that feedback up to the hypothalamus to start decreasing, right? So it kind of goes up and down as it's needed, right? The HPA axis, hypothalamus to the pituitary, pituitary to adrenal. Okay? All right, corticosteroids, synthetic medications that closely resemble cortisol. How convenient. If we have problems, we have medications to help with a solution. But it can also cause problems too, right? Because we use corticosteroids for a lot of things. I know you guys know about that. Because you're giving them probably all the time in clinical, right? Anti-inflammatory action. That's why we want to give them. What patients get corticosteroids? Say again? Transplant patients. Not necessarily for anti-inflammatory action though.
No, that was just the first thing.
She's jumping ahead. No, but it's the second one on there. Immunosuppression, right? She's talking about transplant patients will get corticosteroid. Who else gets? I'm talking about anti-inflammatory. Yeah, arthritis, maybe. We usually use NSAIDs for that, but if it's bad enough. What about respiratory? COPD, right? So it decreases redness, tenderness, heat, swelling, or edema. Anti-inflammatory action. Also, it's useful that it can cause immunosuppression, right? Decrease the immune response. Also helps in reducing the anti-inflammatory piece when it comes to the immune response and the inflammation that results in this. But we give it to transplant patients because it helps avoid that rejection, right? That autoimmune type reaction that can happen when it does not recognize the new organ. Maintenance of normal blood pressure. So corticosteroids act on the renal tubules to increase sodium reabsorption. That results in holding on to that water, right? And increases our blood pressure. Corticosteroids also help with the carbohydrate and protein metabolism. So antagonize the effects of insulin due to increased glycogen breakdown in the liver. So cortisol in the body also helps us in processing our macros, our protein, our carbohydrates, and our fats. So this is where the glucose piece comes in when it comes to corticosteroids. Okay? So corticosteroids, these are the meds that end in the zone, or zone, right? S-O-N-E, hydrocortisone. Long-term therapeutic doses often lead to serious complications and side effects. So if you're on them for a long period of time, this is where we start to have problems, hence today's presentation. Treatment must always be weighed against the risk. So how long are we going to keep them on him? When do we need to take them off or taper them off? So when it's not taken for a steroid replacement, we need, they take it once daily, every other day, in the morning with food. So if it's a hormone replacement, they might have different orders on how often they take it and how much. Osteoporosis is an issue too with this. So we need to teach about signs of osteoporosis, calcium supplements, and exercise. We talked about this back in MP1, it's like deja vu. That helps with that bone, the osteoblasts and clasts that are dealing with this. So when we exercise, we can help build new bone growth with that pressure on those bones. All right. So we're always going to taper doses when we come off corticosteroids. Okay, we don't want to come off them really quickly. Because of the immunosuppression that can occur, we want to watch for signs of infection. And because of the response with glucose, we also want to watch glucose because it'll rise if you're on corticosteroids for a long period of time. So a patient who might also be diabetic and on corticosteroids are probably going to need an adjustment to the medications. Increase their oral dose or increase their insulin dose. Okay, so we wanted to talk about corticosteroids because earlier on, because chronic use of them could have issues. So hypercorticolism, or hyperadrenal, so too much cortisol is Cushing's syndrome and disease. So the causes could be exogenous or endogenous. You've heard those terms before. Exo is outside of the body. So in the case of somebody who's on chronic corticosteroid replacement, or too much cortisol taken into the body. And then the endogenous causes. So something's happening in the body that's causing an increase in cortisol. So an overproduction of the adrenals in producing that cortisol. So tumors can do that, benign or cancerous type tumors, directly in the adrenals. Or there's an increased production of that ACTH. You remember that comes from the pituitary gland. So that would indicate a pituitary type adenoma. So when it is stemming from the pituitary, and we have a problem with ACTH, that is when you have Cushing's disease. Okay? So not necessarily stemming directly from the adrenals, but from the pituitary. So Cushing's syndrome, and Cushing disease is similar to Cushing's syndrome. They usually, the words are interchangeable, just know that the disease has to do with pituitary, the tumor in the pituitary. So with this disease, the syndrome, you can have central obesity, and it's underlined because that's your primary, the weight increase in the abdomen area, right? And in the face, we've got that, they call it a moon face, that rounded face. It sounds mean. We also have extra fat deposits on the back of the neck, and they call it a buffalo. These are like NCLEX type terms. One of these days they're going to get rid of them, but they call it a buffalo hump. So if you see the moon face and the buffalo hump, you think Cushing syndrome, increased glucocorticoids. So that persistent hyperglycemia, right? And then there's also muscle wasting that occurs. Let's see, the central obesity is the most common. So because of the induced insulin resistance, we were talking about diabetics need to increase their insulin usually. About 60% of the cases are going to have that muscle, the breakdown of the protein in the muscle and that muscle wasting. So not everybody's going to have that, but that muscle is breaking down there. So you have that insulin resistance, and so that's that, you're breaking down muscle protein to get energy, so you're going to have that muscle wasting. So the osteoblasts exceed the osteoclasts, so there's more breakdown of bone than there is of rebuilding bone. There's that osteoporosis piece. That's in 80% of the cases. So that's why there's a lot more teaching on the osteoporosis piece. So corticosteroids over a long period of time, and you're also dealing with somebody who may be elderly, who are already at risk for osteoporosis, and now you're taking these meds that are causing it because your COPD is really bad, and you have these corticosteroids to help with inflammation, and now we're looking at osteoporosis that's probably worsening because of the medication and their age, etc. So that's probably why that's 80% of cases have that. There's loss of collagen from muscle wasting. So that's why you see the purple striae. It's really just like stretch marks or petechiae in that area. The primary reason for that is that increased weight gain in the abdomen and upper thighs. You'll see it there, but because of that decrease in collagen, it causes this micro bleeding of the capillaries. So the neurological changes, some irritability, some confusion potentially, or concentration, anxiety, just some neuro side effects from neuro changes. Increased susceptibility of infection, important about when it comes to those transplant patients, because you might not necessarily see an increased white blood cell count, right? Because if you're suppressing the immune system, you're not going to be producing the cells that help fight infection. So you have to look for signs of infection elsewhere. So don't always just rely on that white blood cell count. Think about what else is going on, what might be causing immune suppression. Do they have a fever? That's going to be your number one sign for infection in someone who's immune compromised. You might not have an increased white count. Okay, so that's on the corticosteroid side. Remember, the cortex also deals with the mineral corticoids and the androgens. So some other signs and symptoms you might see when aldosterone is increased. Right? We were talking about cortisol and fat deposits. Now we're talking about cortisol and sodium, increased sodium and water retention. Right? So it's not ADH this time. This is aldosterone that's telling. So remember the renin-angiotensin-aldosterone system that we talked about a long time ago? This is where this comes in, right? So if we've got something going on in the adrenals, we might be retaining water with Cushing's, right? So we've got fat deposits and water increase. So with increased water in our vasculature, we're gonna have blood pressure that goes up. They're also wasting potassium, so we have hypokalemia here. There's an increased acid in the stomach too, so GI ulcers, GI upset, heartburn. So with the androgens, there's skin issues, like lots of adult acne, all of a sudden, a lot of skin problems like they're a teenager again. So increase in those androgens. And there's hirsutism again, the hairy suit. It's usually on the body in men, face in females, that peach fuzz hair. And reproductive, so that has to do with the androgens, those last three. So lots of symptoms with it. So from increased cortisol and increased aldosterone. So diagnosing, obviously we're going to look at plasma. We can test cortisol in the blood. So we can draw some labs, look at their plasma cortisol levels. And most people are cortisol, it's up and down throughout the day, but like in the middle of the night or at midnight, it's usually when we're at our trough, it's at its lowest. So they might check a salivary cortisol, or in the hospital we'll probably just draw some labs and we'll just go right for the needle and get the blood. But we can check their cortisol level at midnight and see, is it at elevated level even at midnight when it's supposed to be at its lowest? There's the dexamethasone suppression test. So that one, so it's supposed to depress the ACTH hormone in the pituitary by giving dexamethasone. Okay, so they can do this suppression test to see, is it coming from the adrenals or is it coming from the pituitary? So they'll give just a low dose, like 1 milligram at about 11 o'clock, and give it about 8 hours and test their cortisol at 8 in the morning. And so if it's coming from the adrenals, then there's going to be no change, right? But if it's coming from the pituitary and we replace that hormone, then everything's functioning normally, right? So then we'll have a decrease in their cortisol because we're suppressing it. Does that make sense? So really that's just to help them to determine, which came first, the chicken or the egg. Is it the pituitary or the adrenals? So we'll do the suppression test to see if this medication suppresses it. Do we have a normal response or do we have no change? So 24-hour urine cortisol could be done. So 24-hour urine collection, you guys have done that before? And then the orange jug in the ice or the refrigerator, not next to the Gatorade. Its own separate lab fridge in the dirty utility room. Or in the patient's bathroom, and that bucket of ice, that's old. I don't think we do that anymore. We still do? So what if they have end-stage renal disease, and we're going to have to look at one of these other tests, right? So if they're already not putting out a lot of urine, that 24-hour urine cortisol is probably not going to be helpful. So some other labs that might go along with it, just thinking about how these hormones react. So leukocytosis, right? Decreased white count, knowing the immune suppression, right? Hyperglycemia, the insulin resistance, glucose in the urine from that excess glucose floating around. So again, can't just look at one lab, you look at everything all together. It's all pointing towards this Cushing's syndrome. Okay, everybody so far so good? Okay, so treatment now. We want to normalize the hormones, right? So it depends on the underlying cause, pituitary or adrenal, right? Surgery, radiation, drug therapy. So if we're just replacing the hormones, medications will work, or if we have some kind of tumor, we can maybe do some surgery. So a pituitary adenoma, so they're going to do that radiation, and then we can do that transsphenoidal hypophysectomy that you guys saw the video for, right? And remove that tumor, and it takes care of that ACTH problem. Or if the tumor's on the adrenals, right, they can go ahead and remove. Remember I talked about vascular, supervascular. So for removing a tumor or a portion of the adrenal, we're probably going to have to now replace that hormone. So even though it was causing an increase, we've now removed the ability to even produce it at all. So we'll likely we'll swing them the other direction into an adrenal insufficiency, so they're going to need to have those steroids replaced. Just like if it was removing the pituitary, there might be other hormones they have to take for the rest of their life to replace that. So surgery is likely going to have us give them some more hormones. So we cannot skip these. So even if the dose is like missed or late, give it right away. We notify the physician, retime it if need be. So again, there's some other organs that can produce hormones that mimic. So sometimes those tumors are removed and it takes care of the problem. So obviously monitoring for infection are one of our goals. 24 to 48 hours post-op is critical because of that severe drop in cortisol, right? So if we've removed a tumor and there's no way to produce hormone, we're going to replace it. But there could be that adjustment period, and plus the risk for bleeding at the same time too, very vascular space. So those are some of our critical pieces that we're looking at right in that first post-op period. So daily labs and urine, vital signs, thinking about all the effects, all the blood pressure issues, sodium, electrolytes, all that stuff. Okay, so Cushing's disease and Cushing's syndrome is when we have too much cortisol, right? So now we're hypercortisolism. Oh, I said it that time. So Addison's disease. So adrenal insufficiency or a hypofunction of the adrenal cortex. Usually it's an autoimmune type response. Okay, body is fighting it and now it's not working. Right? So it's not giving the cortisol that's needed. I've seen this in pediatrics too. This is out of the endocrines. This is one I've probably seen a little bit more than the others. So secondary cause, lack of pituitary gland. So is the issue with the adrenals or is it at the pituitary and the ACTH secretion? Okay, so we were talking about the three different types of steroids, the glucocorticoids, the mineralocorticoids, and the androgens. So it's not producing enough of them. So your symptoms are going to look a little different. So we're talking about weight loss now. Loss of appetite, nausea, vomiting, diarrhea. Hypoglycemia, we're swinging the other way, right? Weakness, abdominal pain, diarrhea is already in there. Hypotension, because of the hypovolemia. And that also includes the orthostatic type hypotension, so the drop or the change in position. There can be a hyperpigmentation in the hormones, sort of darkening in the skin. Salt craving, hyperkalemia, joint pain. So that serum sodium is dropping and potassium is increasing. Right? So think of what that's going to make you want to monitor. So diagnosis and treatment. So we talked about this ACTH stimulation test. And of course, they're going to need a lifelong hormone replacement. Because usually this is like a permanent reason for, they can't get them to stimulate this hormone secretion, so they're going to have that replacement. So we're teaching about blood pressure monitoring, increased salt intake. Isn't that nice? Aren't we always trying to suppress salt? Teach patient and caregiver how to give IM injections, because that's how we're likely going to replace that hormone. And there's an emergency kit that they carry around for this Addisonian insufficiency or the crisis. So when there's high stress, or even like, we'll talk about that in a minute, but there's an emergency kit, like a rescue kit that they have to carry around. So actually, at summer camp, Girl Scout summer camp, I had a girl with her emergency kit because she had Addison's disease. So here they are rowing and doing all these sports and wall climbing. And so anytime she was doing an activity and she had any high stress, the nurse had to kind of be there just in case to give her her IM injection or hydrocortisone. So thankfully we didn't have to give it a few times. People get nervous around people like this. It's kind of like your hemophilia patient who, with injury, you're kind of ready with their rescue to replace and take care of emergencies. But in moments of stress, when you don't produce enough cortisol, you need this cortisol to protect your body. So we'll have to replace with the hydrocortisone. So this is the emergency that I was talking about, was life-threatening. Low steroid levels, adrenal insufficiency, or a sodium crisis. So missing their therapy, missing their medication can throw you into an adrenal insufficiency. Physical stress, any surgery, so that's what I was saying. If we're dealing with Cushing's and now we've had surgery, we're completely dropping them into this adrenal insufficiency, so we need to make sure that we're replacing. So the surgery can cause this damage to the pituitary. So same symptoms, we got tachycardia, hypotension, dehydration, hyponatremia, hyperkalemia, right? So we're gonna put them on a heart monitor, watch for arrhythmias. Fever, weakness, confusion, loss of consciousness. So because of the hypotension that results, this is why this is an emergency, because now we have circulatory collapse, right? We've got nothing circulating. So normally we think about an IV fluid bolus when we have hypotension and circulatory collapse, but it's the steroid that we need. We're gonna do both, but we definitely need the steroid or we're not really gonna have an effect. So we need vasopressors to help with fluids, but it's the corticosteroid that's gonna replace and get them to process better. So Solu-Cortef is the brand name, but hydrocortisone by injection is what's given. And then we're gonna go ahead and replace those losses with like a normal saline, isotonic type bolus. Okay, so that's that piece. Got some questions I can pull up for you. Everybody good? Letting it marinate? Actually, I'm going to get you up and moving a little bit here. So in Moodle, I have a worksheet, but I'm going to pass this out for you guys. You can work together or by yourself if you want. Depends on how many pieces I have here.
Thank you.
Pressure back up.
Oh, this is it's a group thing. Okay. You're upward, low, high.
We're just putting X into it. Oh.
What's increase? So you're diluted.
Is it your serum osmolality high?
No, here you get hyponatremia. Here you get hyper, so low and low. Yeah. Here's in high because
All right. All these should, I think it works out increase or decrease. That's the last one I told you,
No, I
that
mean,
says
the,
which option to pick.
I thought you had
no, here you have the ground for Tumba is hepatitis. So it's like hypotension.
so then the DH has to be high because you're losing all your water supplies.
But yeah. So it levels here that high because the high and then it increase.
That's your specific diet. So that's called concentrated.
Here it's high, here it's low. Because at that,
Plasma osmolality is high and low here. This is high. Yeah, your blood. I'm almost
that the during high here, right? Because the peak. Oh yeah.
Oh, yeah, I have it screenshot. Oh, yeah. Just to know if it's okay. But you did hurt my feelings really bad. Yeah.
Oh.
Like I said, we screenshot.
Oh, I'm so sorry.
I'm so sorry. You know, I'm kidding, right? Big girl. Specific to. I don't know if it's the way it's 23.
During osmolarity is high, is high. That's what I thought, yes. It's high than the serum is low. Because I think this is the same.
urine is diluted with DI.
Yes.
So it would be high here.
Yeah, and this would be high. It's in the pathway. And it's low here. Because urine I think it's the same. It's just like, what is the concentration?
Oh, you put it on there. Okay, yeah, so that's on there, it's just the test.
Yeah.
It should be, it was neat though.
Yeah. So it's the same as specific practice.
Yeah, it it so far anyway, but. Oh, yeah, mental health is on there. Yeah, those are on that too. Okay.
Which kind of makes sense? Water, so like the plasma would be increased. So then the DH was high. Extracellular, this is
Everybody ready? Go through it? So on, let's look at urinary output. So if you have increased antidiuretic hormone, what's gonna happen to your urine output? Down, right, because you're holding on to that water, right? So then if you have diabetes insipidus, up. Okay, serum sodium, SiADH, decreased, right? And so insipidus, urine specific gravity. So if we're holding on to fluid and we have, yes, where are we? Increased specific, so it's more concentrated. This is urine specific gravity. Do you get that? On SiADH, urine specific gravity is increased. So it's more concentrated in the urine. It's low output, but what little urine you do have is going to be pretty concentrated. Okay? Because the water has stayed inside. Does that make sense? Everybody got it? So on insipidus, it's decreased. Okay. So ADH levels for SiADH, are we increased or decreased? Increased. And so for diabetes insipidus, down. So urine osmolality for SiADH, so concentration of urine, yes, increased. All right, we just talked about that. Decreased with diabetes insipidus, you got it. So plasma osmolality, decreased in SiADH, yeah, because it's the dilution of the hyponatremia. And then, so diabetes insipidus, increased. Extracellular fluid volume for SiADH, no trick there. and diabetes insipidus, decreased. You get it. I'm watching thumbs up and down back over. All right, where are we? Water reabsorption of the kidneys, increased in SiADH. Yep. Decreased in diabetes insipidus. So what about blood pressure, SiADH? High. We got fluid overload. So then what happens in diabetes insipidus? Decreased. So this one isn't an increase or decrease fluid status. So what do we have for SiADH? Is it a restriction, right? We got too much fluid, right? And so for diabetes insipidus, what are we doing? Restricting, maintaining, or low?
We give them a little until they reach the point of.
We were just talking about it. What did you say down here? We maintain. So if we replace the hormone, we don't need to bolus because they're going to start holding on to it. So there's no, it's really just to maintain their fluid status. And we didn't talk about it in the lecture, but it's maintenance. Maintain adequate hydration. Once we start that hormone back up, then they're going to immediately start holding on to some fluid. Okay? Did that help a little bit?
Yeah.
I know, with everything up and down, so you just start with what's initially happening and you can think through the rest of it, okay? All right, I've got some questions to put up on the screen. I know we're finishing a little early, but we're gonna do a couple of things. Maybe we'll still get out a little bit early, but a few things to talk about. There was questions about ATI, and I guess we're putting up the percentage, the leveling percentages for you, so you have that to refer to, because that's coming. I know that there was a question about that. We're gonna go through some questions on pituitary and adrenals. And then after that, we have time, you guys are, since you're here, you can work on your global assignments too, if you have that stuff with you. You can start working on that, or your EVP projects, and your knowledge checks for the calcium and phosphorus piece. Okay? Because there's some of you who might still need to do that. So let's go through the questions. Okay, developing a care plan for a client with SIADH. Which of the following would be a potential nursing diagnosis for this client? Easy peasy. SIADH, but no, we're gonna look at the rationale here. Presents with low urine output, high urine osmolality and specific gravity, low plasma osmolality, weight gain, and elevated blood pressure. Okay? Which patient is most at risk for developing syndrome of inappropriate antidiuretic hormone? So risk factors, which one's most at risk? Diagnosed with small cell lung cancer, kidney tubules are failing to reabsorb water, tumor on the anterior pituitary gland, remember where ADH comes from, and patient taking declamycin. Who said A? Who says B? No, I don't have the little Professor Bristol things. Small cell lung cancer. Remember that was one of the first signs? So, small cell lung cancer is associated with inducing SIADH. So the kidney tubules failing to reabsorb water, that has to do with diabetes insipidus, right, from the renal side, right? Tumor on the anterior pituitary gland would not cause SIADH, it would be posterior. And patient taking declamycin is trying to induce nephrogenic diabetes insipidus to reverse, okay? So it's suppressing ADH. Or sorry, stimulating ADH. Okay, so where is cortisol produced? Cortisol is produced in the cortex. Yeah. Yeah. Also produces aldosterone and your androgen hormones too. Right. Pituitary growth hormone, adrenal medulla, the catecholamines, their fight or flight. Posterior pituitary stores ADH and oxytocin. Right, the O, a fly pet. Patient is admitted to the hospital with a diagnosis of Cushing's syndrome. On their physical assessment of the patient, what manifestations would the nurse be looking for? Select 4 that apply. There's a lot on this one. Hypertension, peripheral edema, hypotension, hypoglycemia, hyperglycemia. Yeah. So, patients admitted to the hospital with Cushing's, hypertension, peripheral edema, hyperglycemia, and petechiae, which is that really one of the purple striae from that. There you go. A nurse is asked to collect a plasma ACTH level. The results come back as undetectable. the nurse knows that the HCP, the healthcare provider, is going to be treating the patient for which endocrine disorder. So ACTH comes from pituitary stimulating, or comes from the hypothalamus stimulating the that's growth hormone. What do you want to say? He's doing sign language. So it's a hypofunction of the adrenal cortex, lack of pituitary gland production of the ACTH secretion, right? So it's not secreting it. So it's coming from pituitary. So it's a central, right? Acromegaly is growth hormone, right? SIADH is an increase in ADH. So if they're not detecting the ACTH, you can't get your ADH. I know, so many letters. Cushing syndrome is caused by an increase in cortisol, okay? And an increase in ACTH production. Got it? You'll come back to it. Draw out your little diagrams. Rewrite your notes. Look at this activity again, the increase and decrease, although don't memorize it, understand it, right? A nurse is admitting a client who has acute adrenal insufficiency. Which of the following order should the nurse expect to receive from the provider? So acute adrenal insufficiency. So this one's a little more difficult because it says the select all that apply. It doesn't tell you exactly how many, right? Kind of tricky in there, right? So you got two different fluids in here. I'm hearing some letters that have to do with fluids. So we got half normal saline. So think of your hyper, hypo, and isotonic solutions. So what ones do you definitely know? C. You're saying A?
It's maintained, right?
B.
If it's maintained, it's hyper.
Okay, so it's kind of tricky, so let's walk through it. I know, right? So they're hyponatremic, so they don't want to give a hypotonic solution. They're going to need normal saline. Right, so we're talking about fluid replacement, right? I'm sorry. B, these patients are hyperkalemic. They need regular insulin to shift. This is what's tricky too. Potassium and insulin. Insulin's going to cause that potassium to shift back into the cells. So we will give insulin to do that. Okay, so it's not always about glucose. Actually, when you guys get into NP4 and talk about ketoacidosis, diabetic ketoacidosis, probably going to look at that more than insulin, even though we'll be on an insulin drip. I don't want to get too far ahead. That's why this one's a little tricky, because you might not have been thinking that way. I know your brain goes right to glucose when we're talking about insulin. So that's a little preview for what's coming. A little harder question on this one, but it'll help you understand it. So cellular cortef, you guys knew, because we just talked about that. The sodium polystyrene sulfonate.
Oh, should have said
It's
Kayexalate.
I know. So it absorbs potassium. You guys given Kayexalate for hyperkalemia before? No. So it binds with the potassium to help release it, right? Which is also why we're giving furosemide, right? Remember we talked about hyperkalemia? We didn't focus a lot on it, but that's why, because I knew this one was coming for you. So I wanted to help hone that into you. So there's 3 different ways we can get rid of that potassium, but we're going to be watching and putting them on a monitor too. Because when we're playing around with potassium, we got too much. We do all these things, we're going to completely deplete their potassium too, right? So probably won't do all 3 at once. Probably just do 1 and see and recheck. And then if we need to add more things to it, like the Kexalate. Usually just gonna do the furosemide for that. And then the 50 mils of dextrose, right? Because the insulin is gonna take care of the potassium, but now we might drop the sugar, so we're chasing our tail. So we need to give them some dextrose. So it's only 50 mils, it's not a bolus of fluid, and D50 is like syrup. I'm pretty sure most of you have not pushed that yet, but it is like thick. If you ever, once you get a chance to do that, hopefully you don't have to. It's not usually fun when we're having to give D50, it's usually pretty emergent. So we're talking about adrenal insufficiency. So this is a little higher urgency in their care. But this was a good question to kind of break apart what's going on here when we're talking about the electrolytes and what's happening and what kind of things we can do to treat that. You had a question?
Is it thick, like, you know the tubes that you give them, like, people on your consult?
The 50 mils?
Is it thick like that?
It comes in a 50 ml syringe, or we'll pull it up in a 50 ml syringe, but because there's so much sugar in it and viscosity of the liquid is really thick. But yeah, so picturing it, it's really more about the sugar. It's not an IV solution for hydration. It's just sugar replacement post dropping their potassium. Yeah. Okay, very good. Did that help you? I know it's a hard question, but at least it broke it down a little bit. All right. Next one. I don't know how many there are. Patient arrives to the ER and is unable to give you a health history due to altered they're unstable. They're unstable in the mental status. Family reports the patient has gained over 10 pounds in 1 week and says it's mainly water weight. Where are we going with this? In addition, they report the patient hasn't been able to urinate or eat in the past week, as well as recently diagnosed with small cell lung cancer. This one's throwing it all at you, right? On assessment, you know their heart rate, BP, sodium is 112. That's scary, right? Which of the following conditions? A, you're getting it. Weight gain, water weight, right? Decrease urine output, hyponatremia, elevated BP, all that fluid in their vessels. They threw it all at you.
Wait, this,
You got it?
no.
These are, I think, this is in rule too. So you guys can go back through these again when you're studying too.
Why is the sodium level high?
It's low, it's diluted.
Oh, it's, okay.
135 and 145.
You know what
You got it?
Yeah.
So, in the previous scenario, SIADH, which drug do you anticipate the patient will be started on? Right? So, daclomycin is used to induce the nephrogenic DI to help normalize SIADH. So desmopressin sounds like vasopressin. When you want EH, that's the one you go for. Right? So DI, that's a treatment for DI. That helps you remember your medications a little bit. So dec low is when you want it low. Desmo is when you want mo. I don't know, I'm just thinking. That might help you, right?
Yeah.
Do what you gotta do. All right, chlorpropamide, it's not even in the US anymore, but it's an anti-diabetic medication. It says for diabetes mellitus, but anyways, we can forget about that one. And indomethacin helped reduce urine output related, so we didn't talk about that one, but so we can take other medications to kind of counteract, but your primary one, we want the hormone to stabilize, so those are the meds that we're gonna go for first, and all these other meds that help in other ways to reduce fluid, increase blood pressure, et cetera, will then be added to it. But that's where we're gonna focus our meds, okay? All right, so we're gonna take some time. We have 45 minutes. We'll probably go ahead and let you go a little early, but let's get some work done first because it's too early to let you go. So pull out, you guys can get in your groups and work on your global assignment. Do you have things you can do with that? What about your EBP projects too?
Can we work on studying for tomorrow?
Yes, you can do that. if you have questions as you come across that. Knowledge checks, if you are